So welcome everybody to Better Health Partnership's 2021 virtual annual report to the community. The topic of our report this year is to focus on elevating children's health, and the webinar this afternoon is going to focus specifically on the results from the Children's Mental Health Initiative. It's been part of Better Health Partnership. Next slide, please. My name is Donald Ford. I'm the Chief Medical Officer of Better Health Partnership. I'll be the moderator for today's webinar. Next slide, please. We have just a little bit of business to attend to start out with. Everybody is on mute, so don't feel left out. We find it's easiest to communicate that way, to take advantage of the technology. We do ask that people submit their questions, and we will have time for questions at the end. Submit them through the chat. You're more than welcome to submit questions as the webinar is going on, because you may think of something that's timely. Part of my job will be to curate those questions and to make sure that we get to them at the end of the session. But the question and answers will be at the end, so feel free to use the chat throughout the presentation. The slides from today's presentation will be posted on our website, so don't feel like you need to take copious notes. Next slide, please. And for those of you who are not familiar with Better Health Partnership, I'd like to give just a brief introduction of who we are and what we do. We're a nonprofit regional health improvement collaborative that brings together healthcare, social services, public health, payers, and other sectors to share best practices and accelerate data-informed improvements in equitable population and community health. We're part of a national network of health improvement collaboratives, and we also share best practices and unify at state and national levels on innovative opportunities that help to bring greater health value to our partners into the region. We've been working with our Better Health partners since 2007, and together we've demonstrated widely recognized collective impact on the health and health disparities in Northeast Ohio. Next slide, please. Here's today's agenda. As you can see, we're jam-packed with a star-studded lineup. We're focusing on the Children's Mental Health Update, and we'll start out with Dr. Mary Gabriel, who's going to talk about the Children's Health Initiative, Mental Health Initiative. Chris Mundorf from Better Health Partnership will go through data from our behavioral health pilot. We have Martin Williams, who will give us an overview on becoming a certified community behavioral health center. And Loren Anthes has joined us to talk about an exciting new managed care program for youth with complex behavioral health needs. Next slide, please. We will take questions at the end of the webinar, but again, please feel free to submit them in the chat throughout the session. And it gives me great privilege and honor to introduce Dr. Mary Gabriel, who is the chair of Better Health Partnership's Children's Mental Health Subcommittee. Dr. Mary Gabriel is a child psychiatrist at University Hospitals Case Western Reserve University School of Medicine. Dr. Gabriel.
Thank you, Dr. Ford. I will jump in. As you said, we have a very packed agenda today. So we'll just go right into the work of the subcommittee. Next slide, please. So I think to really understand the scope of what we were trying to do, it is instructive to look at the state of affairs, and that currently the pediatric mental health crisis that we had been experiencing through the years over the last 10 to 20 years has really exploded and been amplified by the coronavirus pandemic. And a lot of the studies that are coming out are showing just how severe the impact has been with quarantine and the shifts in sort of social existence for the children in this country. Multiple statistics, multiple studies in different areas and different arenas are revealing struggling children. We know that the number of admissions has increased in the hospitals. We know that early on in quarantine, depression screenings actually decreased just by virtue of there being fewer visits initially. However, the scores on pediatric depression screens had increased. The number of admissions to inpatient child psychiatric units also increased, with higher proportions being directly related to COVID. Last counts I saw were that over 50% of all inpatient admissions to child inpatient psychiatric units were directly related to COVID. Mental Health America, as well as SAMHSA, Better Health Partnership itself, and organizations like the Trevor Project have also identified increases in mental health acuity within our pediatric patients. Next slide, please. So overall, where we had started, statistically, about 20% of the children in the United States will suffer from some form of mental illness. So if you imagine 1 in 5 of the children in this country experience symptoms like this, and then take into account that only 1 in 5 of those children actually receive some sort of treatment, a significant proportion of our children continue to struggle and go unattended in their mental health. Unfortunately, not a lot of them come to attention until much later after presentation of symptoms. Partly because some of these symptoms are more internally experienced and don't necessarily have external signs and symptoms, but more because their resources are lacking and awareness is lacking to even start picking up on a lot of these symptoms. So the average delay of onset in pediatric patients coming to attention is 8 to 10 years. If you can imagine the amount of development that occurs in a child's brain during that time, it is a critical window, and you can really affect the trajectory of a child's future based on interventions that we can do now if we can identify and intervene early. So what's also really interesting is that 75% of children with a mental illness do present to their pediatrician's offices. So even though only 20% of 20% ever get specific mental health care, they do present to healthcare with their diagnoses and with their symptoms. So really a critical engagement period that we can capitalize on to help these children. Next slide, please. However, even when they are identified, we struggle because the resources available to help these children as it stands now are woefully inadequate. There is a dearth of child psychiatrists in the United States, and we are better populated regarding child psychiatry than most countries in the world. So estimated a little less than 9,000 child psychiatrists in the US, and we have to cover 15 million children. If we estimate 80 million children in the US and 20% of those have a mental illness, then we're responsible for 15 million of them. SAMHSA and the CDC, looking at adequate workforce, predicts that the United States actually needs over 50,000 child psychiatrists to adequately meet the need. And then on top of that, the pediatric population is supposed to grow over the next couple of decades, almost doubling to 112 million by the year 2050. So that gives you sort of an understanding of the workforce, and yet the demand grows, the acuity grows. So mental health disorders are now beyond and have become the most common conditions that are reasons that children have impairments and limitations in their functioning. We have seen that suicide is now the second leading cause of death in 10 to 24-year-olds nationally. And then in 2019, the ODH in their studies found that suicide is now the leading cause of death in 10 to 14-year-olds within the state of Ohio. Next slide. So being aware of this, VHP took a particular interest in children's mental health and decided to dedicate some of its focused efforts on addressing these issues, and decided to create a subcommittee within its Children's Health Initiative. And to understand the makeup of the committee and the inputs that are being solicited to try and address the issue, we really start with looking at the child and understanding the existence of children, knowing that they exist in various domains within their lives, whether it's within the domain of home and family, the domain of school, within their community, their relationship with healthcare and their physicians. There are many different inputs and influences in a children's life, relationships that we can capitalize on. And I think BHP was very cognizant of this and sought to get these different perspectives in addressing the issue. So as you can see here, we have pediatricians from Northeast Ohio from 2 different hospital systems. We have community partners, including the centers with Martin Williams, who we'll hear from a little bit later. We have school involvement, including the Director of Psychological Services within the Cleveland Municipal School District. We have child psychiatrists for both Cleveland Clinic and university hospitals who practice in various areas, both in the community as well as school-based services and academic-based practices. And then we have community partners involving Case Western Reserve University and their expertise. Next slide, please. So identifying the problem, rising rates of mental health and acuity in children. Our aim, putting all of our experiences together, was to try and standardize mental health prevention, identification, and intervention for children in various domains, whether it's primary care, behavioral health, or their educational systems. Understanding that there are various points of access to get to mental health care. Next slide. So putting together our experiences, we realized that they sorted out into 3 buckets, and that's what informed our SMART aim: prevention, early identification, and intervention. And sorting these different experiences informed then our goals. Next slide. So our goals really were to try and catch these children as early as possible through screening processes, coordinating their care with the various domains in which they exist, and then strengthening all of the adults and the authority figures within each of those domains to be able to intervene and improve their symptoms. Next slide. So these are the guiding principles that we used, really focusing on equality, cultural appropriateness, inclusiveness, and equity, as well as using an outcomes-based and evidence-based approach, and really focusing on primary prevention to build resiliency in the kids. Next slide, please. So how do we do this? About 7 or 8 months ago, we began to embark on putting all of these thoughts together into a key driver diagram and trying to understand the breadth of the problem and the various factors that that contributed to our state of affairs and what we would like to see different. Next slide. And so this key driver diagram just continued to evolve until we felt like we had exhausted most of the elements that contribute to the issue and the things that we think could be helpful in addressing these issues. Next slide. So that took 5 months, 6 months. We took all those change ideas and looked at the feasibility of each of those ideas, as well as the impact that each of those could make. And looking at those, a few themes emerged. One was that school-based services would be highly feasible with high impact, as all children are in a school environment, no matter where else they exist in their lives, and that there are adults that engage with them continuously for 8 hours a day that really have an impact. And then on top of that, care coordination and collaboration between all of the different resources and origins of service within a child's life really contributes to their outcomes and wellness. Next slide. So realizing this, we decided to start looking at our community partners to see how we could engage with their resources and knowledge to inform pilot programs that we could try to better address these issues. And these include things like the Ohio Suicide Prevention Foundation, OHIP and CliniSync in trying to enhance collaboration between different agencies, as well as ACAP and their school psychiatry committee. Next slide. So coming to this pilot, we decided to focus on 4 different areas. One is to identify children as early as possible, whether within a healthcare environment or a school environment, and using broad universal screening tools. Next is to share the findings with people who can do something with those findings, namely mental health providers and PCPs, and then training the adults who exist in a child's world in order to support, recognize, and then intervene at appropriate intervals in order to best address these issues. Next slide. So I was asked also to share some of what we do at the Rainbow Center, but I do want to be mindful of other people's time. I will just say quickly that we embarked on an integrated mental health program at the Rainbow Center using universal screening. We have called our screening tools just to make sure that there would be no screening fatigue. And so this is where we were at the height of our screening. Next slide. Once universal screening was performed and concerns were identified, we would then go to more specific diagnostic tools to try and identify the particular issues children were experiencing. Next slide. We came up with workflows in order to best engage the most appropriate resources of help for these children. Next slide. As well as supporting staff and training them how to best support the families as they go through this. Next slide. Well, I'll skip over this slide, it's just extra information. We also educated faculty and trainees through different educational events, including grand rounds, CME events, didactics, and rotations for both trainees and faculty. Next slide. Finally, we embarked on a partnership, a pilot program with one of our community mental health centers, which Chris Mundorf is going to talk about in the next minute or so. And so I will leave that to him to tell you more about. Next slide. I was asked, what would this look like in a perfect world? Early screening. All adults who engage in children have competencies in which to recognize and then appropriately refer, and that systems would support this kind of engagement with children, no matter what access point they use to engage in mental health care. Next slide. All right.
Mary, thank you so much. How you culled those many months of work into 15 minutes is remarkable. There are a lot of questions in the chat, which I hope we'll have time to get to. Now I'd like to introduce Chris Mundorf, my friend and partner from Better Health Partnership. He is the Director of Data Analytics and Reporting for BHP, and he will talk about the pilot results.
Yeah, thank you, Donald, and thank you, Dr. Gabriel. I'm just here to kind of add on a little bit of what Dr. Gabriel really did a good job of giving an overview of. Next slide, please. So again, as a part of the formation of the subcommittee, we wanted to give Dr. Gabriel and the subcommittee members a sense of the central problem she described. So over several months, we conducted a landscape analysis of sorts of how pediatric behavioral health was managed in the healthcare space in Northeast Ohio. We did surveys, we did interviews, and as she described, we really saw these 3 buckets of concerns. One, there really wasn't this consistency in how healthcare systems were screening kids, what they were screening for, when they were, how they were screening. And I think the pilot she described at Rainbow, advancing this way to making a more standardized approach of getting kids screened when they come in. Secondly, we saw this big problem of, what happens once a kid is identified as having a need. Providers, are doing quite well at making internal referrals. Systems have been getting better and better at really integrating behavioral health into primary care. However, once it became apparent that a kid needed to be seen by someone outside the system, it got to be quite messy. One provider describes it as sending someone into a black hole. A lot of these processes still rely on fax machines, and they never really knew whether a referral worked and how often. They found that a lot of the patients weren't following through with the referral, and it created a bit of a vicious cycle where it kind of cut kids off from care that was existed in the community, and further sort of divided the provider with these community mental health agencies. And lastly, as Mary described really astutely, there was a lot of pessimism about whether there was even enough resources in the community, both in terms of capacity, so the wait times that existed for a lot of these kids in need, and then capability in terms of barriers that existed in terms of location, language preferences, or many other unseen cultural barriers that might give us a false impression that kids and their families are choosing not to follow through with care, but because those barriers exist. Next slide. So as Dr. Gabriel described, this was embedded in the development of our driver diagram. And while Rainbow was really focusing on improving that first bucket, we wanted to find a parallel approach to maybe work on that second bucket of improving the referral process. Next slide. So Dr. Gabriel and Dr. Vince Caringi, the Director of Psychiatry at the Centers for Family and Children, decided that the two organizations would be a good place to model a potential best practice. And we at Better Health work to facilitate this as a cross-system QI work. So working together, they described in broad terms what they ultimately wanted to build together, namely a process that would make referrals easier to make a warmer handoff to increase the odds that the child would not get lost in the process, and create a more sensitive approach to ensure better communication between the care teams across sites. One that ensures patient privacy, doesn't overwhelm the provider with too much information, but gives kind of a Goldilocks, just the right amount of information that the care team needs to do the best job it has. Finally, an appeal of piloting a project with centers in Rainbow was they use different EMRs, electronic medical records. This would force them to come up with a low-tech approach that would be agnostic to which EMR the entity was connected, that ultimately would allow this to be scalable to other community mental health agencies across the region. Next slide. So we set up a series of meetings between Rainbow and specialists at Centers for Family and Children. These meetings gave an opportunity to better educate the providers on the services that centers provide and which kids might be the best fits to refer. It allowed the providers to talk with folks at centers to help them understand their typical referral process, the barriers that they ran into. And then from these discussions, centers created their own new streamlined process to receive referrals from Rainbow. This included creating a new HIPAA compliant web portal that existed alongside of options to call or email, and also a unique workflow that was established to connect the referring person with a person at the centers. Next slide. So actually just an hour ago, I got updated data. I got an update from the centers that said that they just recorded their 100th referral, which is amazing that to receive that many referrals in just 6 months. And what's even more amazing, that more than 2 in every of the 3 kids that referred the centers were successfully reached out to schedule an appointment. 70% of those that have gotten their appointment have already been completed and they're engaged with care. And then every successful referral has been relayed back to the social worker at Rainbow. Next slide. So I just want to focus on that one particular number, which I think is outstanding, is this contact success rate. This is unusually high for those not in this field. To show the difference, I wanted to compare with a similar project. This one was tracking referrals from a doctor's office to community-based organizations looking at social needs. And this other project has been going on since 2019, so we have a lot of data. And what's just based on this preliminary data so far is actually statistically significant in its difference, where kids referred through this process were 32% more likely to have been successfully contacted for follow-up. Some of this may be due to type of need, but I think a lot of this is really driven by that workflow that was established between Rainbows and centers to ensure a warm handoff. So next slide. So this pilot isn't over, and it's actually entering the most critical phase, a boring phase, but a critical phase, maintenance. We had a meeting between Rainbow and centers to identify other ways to improve the process, to even improve the contact rate even more, and improve the feedback loop. And I think there's a desire to create a more thorough evaluation, both from a Rainbow side, so tracking health outcomes, and the center side, tracking long-term utilization and mental health indicators. Broadly, I'm just very grateful for the hard work that was put into this pilot by folks at the centers in Rainbow. And this problem is critically important and so easy to overlook. So while new technology fixes may come along and make it easier to make referrals to CBOs like Unitas or through existing EMRs like Epic, ultimately, that technology is only as good as the underlying workflow that exists between the two entities in the referral process. You know, what are the rules of the road? What are the expectations in terms of feedback? And what are the metrics of success? And I think it's critical that rather than hoping for some panacea or silver bullet, that we need to sort of really dig out the best practices and this nitty gritty of governance and data flow to sort of prepare ourselves to create a broader sort of referral process in the broader Northeast Ohio region. So with that, I wanted to hand it off to Donald to transition to the next speaker, but thank you very much for your time.
Chris and all the team, I can't thank you enough for taking this on and showing that improvements can happen and this can be tackled. As promised, I have the great pleasure of introducing next Martin Williams. Martin is the Chief of Programs and Behavioral Health Care at the Circle Health and the Centers, who's going to give us an overview of becoming a certified community behavioral health center.
Thank you, Donald, for that introduction. Good afternoon, everyone. Currently, the center's received a 2-year grant from SAMHSA to become a CCBHC. Our grant period is from February of this year to 2023. We're currently in our 7th month of implementing the CCBHC model. This is the agenda for the presentation. I would walk through each point from the creation of the model to the benefit of becoming a CCBHC. Next slide. In 2014, Congress passed the Protecting Access to Medicare Act to improve access to quality behavioral health services for those with the highest needs and unmet needs. Section 223 of this act required that the Department of Health and Human Services create a process to certify community behavioral health centers, which led to the Excellent Mental Health Act to establish a guideline around how to become certified, and we created the CCBHC. Now, the services provided that's offered in this model are designed to provide a comprehensive array of mental health and substance use disorder services to vulnerable individuals. In return, CCBHC providers receive an enhanced Medicaid reimbursement rate based on the services provided within the CCBHC structure, even if those services are not reimbursable to the state in the state Medicaid plan. Now, unfortunately, Ohio is not a CCBHC state as of yet. However, we are hoping that our state moves in this direction, and so that we can actually take advantage of the enhancement Medicaid reimbursement rate. Next slide. So our goal with this grant is to increase access to services to clients with the most unmet need by creating a county-wide integration system to improve access to services and create better overall health outcomes for our clients. This would include us working with community partners across different service lines, different systems to develop this integration system. Next slide. So how does becoming a CCBHC benefit our patients and our clients? These are the services required to become a CCBHC. Clients will have access to these comprehensive services that are necessary to help stabilize people in crisis, but also providing the necessary treatment for those with the most serious and complex mental illnesses and addictions. Next slide. The one thing that I want to point out with this slide is that CCBHC providers must attest that they meet the national demonstration criteria for becoming a CCBHC provider. So what does that mean? Staffing that's in the CCBHC must be a reflection of the population being served. Individuals must have diverse backgrounds and licensures. In regards to availability and access, we must be able to provide an array of services regardless of clients' ability to pay. Services must be provided in based on 3 levels of need: emergency, urgent, and routine. If it's an emergency need, the goal would be to make sure that clients have access to specific services immediately. If it's an urgent need, we must make sure that clients have access to services within 24 hours. And if it's a routine need, these are your existing clients, we must ensure that clients have access to services within 10 days. Now, with that being said, this new access process will change the front door of how we're providing services today. However, we do believe by restructuring our system and creating this new system of care will help improve health outcomes for our clients, reduce no-show rates, and help them live a more productive life in a community. With care coordination, we must be able to coordinate across settings within our own organization, but outside with other providers to ensure clients' needs are being met. What we're doing now are developing protocols and partnerships, showing how we're coordinating services with different providers to make sure clients are getting their needs met. Some of the partners that we are partnering with is social service agencies, hospitals, criminal justice centers, as well as the VA. That's just to name a few. And there are reporting requirements and accreditation expectations as well that providers must adhere to become a CCBHC organization. Next slide. These are the 9 services providers must provide either directly or through a partnership with other providers. These services were selected to provide these wraparound services for our clients, emphasizing recovery, wellness, trauma-informed care, and physical behavioral health integration. The goal with these services is to prevent clients from falling through the cracks by offering timely services. So services include 24/7 crisis services, immediate access to screenings and risk assessment, easy access to care that includes behavioral health, SUD, as well as primary care services. And a commitment to peers and family services is so important, recognizing that their involvement is essential for recovery and should be fully integrated in clients' care. Next slide. We incorporated community health workers into our grant that works in the Better Health Partnership Pathway Hub. The reason for that is for many years, the centers has provided case management services in Cuyahoga County. These services are effective and help reduce barriers to those with mental health diagnosis, but we often found that some clients were at risk of mental health issues due to a lack of support around social determinants of health. For some time, we have struggled to find ways to connect these clients to services they needed before a mental health crisis led them to our services. So the Better Health Partnership Hub connects at-risk populations to pathways such as prenatal care, social services, employment, housing, and much, much more. So it was our belief that pairing the prevention services provided through the hub with the services offered through case management services allowed us to practice prevention with those who, without these interventions, would be at risk of a mental health or physical health crisis. In addition to that, the hub allows us to not only address needs of our clients, but it also allows us to address any issues that the entire family may have, which is really important. So these prevention components has been the missing link to community case management, and the Better Health Partnership Pathway Hub provides us with a structure and interventions and financial support to broaden the spectrum of our services to improve overall health outcomes for our clients as well as their families. So what are the benefits of being a CCBHC? Next slide. Well, value-based payments performance is one of the things that I talked about earlier, where CCBH providers will receive enhanced Medicaid reimbursement rates based on anticipated cost of offering these CCBHC services. Again, Ohio is not there yet. They're working towards possibly becoming a CCBHC state, and so we're hoping to be able to take advantage of that. The other one is actually improving access to services, timely services, as I discussed it earlier, based on those 3 levels of need, being able to make sure clients are getting access to services based on what level they are within 10 days. That's pretty amazing in the system that we live in right now. Now, on top of that, we also our clients would have access to services regardless of which door they may come in. They can come from the hospital, they can come from the jail, anywhere in the community, regardless of which door they come in. We want to make sure that clients have access to services within that time frame, that urgent emergency routine time frame. So this grant allows us to create a timely access system offering enhanced, integrated, comprehensive services that improve the overall health of our clients. What else can you really ask for, right? You're providing these wraparound services to meet the needs of our clients, but you can also address the needs of the families as well. It's a pretty amazing model to be able to develop. So I'm looking forward to being able to flesh that out. Next slide. This here is just pretty much talking about regardless of any door that a client's come in, internal services as well as external services, clients would be able to access services quickly based on within 10 days, based on what their needs are. By making sure the clients access services quickly, it would allow us to actually provide more services to clients. Next slide. So with our grant, we are proposing to serve 600 clients our first year and a total of 1,200 clients over this grant period. We're already in the process of meeting these goals. We're already enrolling clients into the program, developing new workflows, hiring additional staff, developing new service lines, as well as developing partnerships to ensure that clients' needs are being met. I think that's it. So I want to thank you guys for your time.
Thank you so much, Martin. That was a great description of the program and the advantages, and very clear message about the power that gives in terms of treating our community. To wrap things up, I get to introduce Loren Anthes, and Loren is the Senior Public Policy Fellow and Treuhaft Chair at the Center for Community Solutions. He is also a lecturer at Heritage College of Osteopathic Medicine, which warms my heart to know that our future doctors are getting to hear the wisdom of Loren Anthes. He's going to talk to us about Ohio Rise.
Thank you very much, Dr. Ford, and I'll pass along that note to some of them when it comes grading time. If we can go to the next slide. So as Dr. Ford mentioned, what I want to talk about is a really interesting and innovative program that the state of Ohio is deploying for children with complex medical needs. And I really want to highlight here that time is of the essence in regards to providers' participation in this program, or at least to get ready for participation in this program, because we're still in the formative stages. So I want to update everyone on where we are and then provide some implications for all of you who may be providing medical services. Next slide. Dr. Ford was very generous in his introduction, but generally speaking, with the Center for Community Solutions, we like to be a resource for the community. So if you have any questions about this or other public policy issues like Medicaid, TANF, SNAP, Health and Human Services generally, always feel free to reach out to us. You can find my email there, and you can find a very unobnoxious newsletter available on our website at www.communitysolutions.com. And if you are more short form in terms of your interests, you can always find my hot takes online at Loren Anthes. Next slide, please. Okay, so the agenda for my piece here: why did Medicaid create this program? What is Ohio Rise? What are the expected benefits? And then how do we plug in as healthcare providers or behavioral health resource agencies? Next slide. So why? So something that we already know is that childhood mental illness is connected with longer term physical healthcare outcomes. Dr. Gabriel highlighted this. I think all of you are in some way aware of this based off the presentations that were provided already, but maybe in your own experiences. But children who experience or have a history of mental illness with conditions such as anxiety, depression, substance abuse, even forensic conditions, are aging at a faster pace, have bigger declines in their sensory sensory, motor, and mental functions, and oftentimes just suffered from this process in terms of how they express themselves in terms of physical outcomes. So, the same folks who experience psychiatric conditions when they're young tend to experience physical diseases later on in life. And when we think about Medicaid's role as an insurer, it plays a big part of many children's lives here in Ohio. It finances half of all children's births in our state. It's also the predominant source of coverage for many kids. The half of the folks who are covered by the Medicaid program are children. So it's important to understand that coverage is a part of this equation, but value in trying to make sure that Medicaid is leveraged from a policy standpoint to achieve value to prevent long-term illnesses in both the sort of economic and policy interests of the state. And in Ohio, we know a few things. Number one, 40% of kids over the age of 15 who are in the child welfare system are in congregate care. 140 kids per day are receiving care outside of Ohio. So in order to get some of these basic services for children with complex needs who are also in the child welfare system, we have about 140 kids per day who are receiving care outside of our state because we don't have the capacity or infrastructure to service them. That's also a 200% increase in 2016, and many of the reasons I think Dr. Gabriel appropriately highlighted here. 38% of youth with multi-system needs have a family history of opioid use disorder, substance use disorder, and/or an SED primary diagnosis. So some of you may have heard the term multi-system youth. That is a scenario where a kid or adolescent who's oftentimes engaged in foster care might be engaged in multiple systems, whether that's Medicaid, developmental disabilities, potentially even the juvenile justice system. And with all of this systemic interaction, how do we connect the dots between these systems? I think this gets at the heart of the type of work that Better Health Partnership does, which is seeing comprehensively in order to really get a population health perspective to improve outcomes and improve the situation for these children. Next slide, please. So what is it? So RISE is an acronym, as we are all want to do in our state. And with any government program that has our state's name, there is no space between Ohio and whatever word we're calling this program. But RISE stands for Resilience Through Integrated Systems and Excellence. And what I'd like to highlight here is that this is a specialized managed care organization. So this is a managed care plan that has a specific sort of focus with expertise in providing services for children with the most complex needs. So these are the multi-system youth that we're talking about. So number one, it's a specialized managed care plan. In particular, for those of you who may be wonks out there, it's a prepaid inpatient health plan. It's a capitated arrangement that tries to align incentives and care management services for these kids through this particular plan. There's also shared governance. So it's not just within the Department of Medicaid, but there is a link between the departments where these children may be engaging, whether we were talking about DD or juvenile justice, et cetera. A big plank and a big reason for this program is to prevent custody relinquishment. So for those of you who do not know, oftentimes parents might fall into this income gap, or coverage may not be adequate enough for these kids to receive these really intensive services. And in order for them to get these services, parents will literally have to give their children or hand their children over to county governments in the state in order to be able to receive those services. And what Ohio RISE is trying to accomplish is it's going to pursue a new waiver as a part of this managed care product that will provide coverage for those services to prevent custody relinquishment. So no longer will families, parents, custodians have to hand over their children to the state in order to receive those services, which is a very important and needed thing in our state. And then finally, and what I would argue is the central point to all of this, there's going to be more coordinated and integrated care and services. So it tries to link local entities like family and children first councils, schools, providers, health plans, and families as a part of a comprehensive network of interest to help prevent the downstream acute care institutionalized approach, and instead ensure that kids have more access to services in the home, ensure that we're avoiding custody relinquishment, so on and so forth. Next slide, please. So some of these services include all the existing behavioral health services with a few limited exceptions. For example, emergency services within behavioral health emergency services within an emergency department. Will include care coordination. So, this is a separate plan from the other managed care plans that the state is procuring. But when a child clinically or in terms of utilization data indicates that they have intensive needs or there's an appropriate referral, essentially this child will transition into this product. Okay, they can transition back to, which is part of the goal. Really, Ohio RISE is meant for the most complex situation. And right now, the estimate is around 55 to 60,000 children. The plan that is going to be managing this is Aetna, Better Health of Ohio. It will include intensive home-based treatment. It will include services in a psychiatric residential treatment facility or a PRTF. We talked about the waiver, but that waiver will help provide that coverage gap so that we can prevent custody relinquishment for some still low income but higher income individuals in the Medicaid program. Mobile response and stabilization services will be available. This will also be covered outside of Ohio RISE through the managed care procurement, but there will be a specific tenor here associated with children with complex needs. And then behavioral health respite for families, which is certainly a service that we could use more of in the state of Ohio. In terms of eligibility, you have to be enrolled in Medicaid. That includes managed care or fee-for-service. This applies to children and adolescents up to the age of 21, so some young adults. There needs to be a documented need of significant behavioral health services, and then meet the functional needs criteria as assessed by the Child and Adolescent Needs and Strengths, or CANS tool. And we'll talk about that specifically. Again, 55 to 60,000 children and youth by the end of year one, and we're expecting that this will take off sometime next year. Next slide, please. So what is the CANS? Many of you may know, some of you may not. It's the Child and Adolescent Needs and Strengths Assessment. This will help assist providers, behavioral health providers, families, and others assist in the care planning and provides clinical decision support. It also helps with eligibility, the level of coordination needed, and the out-of-home treatment options, including QRTP or mental health residential services, SUD residential services, ICF or IBS rate add-ons, so extra payments associated with institutional settings, and then again, PRTF services. Next slide, please. So what are the benefits? Well, depending on the tier of coordination, you might get some limited care coordination to some really high care coordination, depending on what the CANS assessment provides. And then depending on what we're talking about here, the Ohio RISE plan could be the one that's offering this coordinated service, or it might be a care management entity. This could include a behavioral health provider. It could include a hospital. It could include a combination of the two, depending how it's contractually defined and who's involved. But the real idea here is that there's high fidelity wraparound services, so that there's a consistent evidence-based model, that families and youth perspective are included in the case management, that this is driven by choice and is driven by quality, and that there are a continuation of community and natural supports that ultimately meet the needs of the family as the family identifies them. Next slide, please. So how can you plug in? Well, first of all, if you want any background on this program or the population that we're talking about, you can visit our website. You can also go to the state's website. I know that's a complicated link, but the slides will be made available. So it's a live link. You can find out all the information with FAQs, so on and so forth. You can email the state and they will answer because they want providers to be a part of this conversation. And you can email the managed care plan themselves at the email there, Ohio ohrise-network@aetna.com. Next slide. Finally, the state, from now until at least December, because of how the funding has worked with the state budget and other resources, is providing free CANS training to eligible providers. So this 2.5-hour online training is available to anyone who may be interested in this. The costs are completely covered by the state. There will be additional training dates that get announced prior to each month. And for any questions or concerns, you can find the contact information there. You can see the September training dates listed on the right hand of that slide. And then also I want to note that Better Health Partnership was kind enough, Carol, will be sending out material on this training and the CANS tool.
My teacher
generally
sends them to
to
me. You have to take them because of your. I just did. None of this is mandatory, but I'm just doing it. So
can everybody mute their line,
and,
please?
You know, I can move on.
Whoever's
These are all
not
free
muted, please mute your
hour
line.
trainings, and I do them right here.
Thank you.
Thank you.
I'm so sorry.
Oh, that's okay. Listen, it's been 2 years of this. If anyone here hasn't been in that same exact spot, I will call you a liar immediately. Okay. So last thing, these are some of the CANS training dates, but Better Health Partnership will send out information on CANS. Strongly encourage providers who do not have this CANS training, who are interested in participating, to take advantage of this training, to get credentialed, because this is how we make appropriate connections between institutional settings, physicians' offices, community behavioral health centers, and families, so that we can do a better job around issues like custody relinquishment and meeting the needs of multi-system youth. And I think that was my last slide. Last thing, locally, Case Western will be a center of excellence for Ohio RISE. They will help with workforce development. Patrick Canary is a contact there. He's written for us about what the COE will entail, but that's a hot link to explain what the COE does. And part of what they will do, if you have any connections to Case specifically, is they will help define and identify and educate providers and others on all of their practice portfolio considerations, which include Ohio RISE, but go much further beyond that. So for anyone who may be interested in or has connections to Case, this will be an excellent resource for you in an ongoing fashion.
Next slide. Thank you. Thank you, Loren. Marvelous description of some of the resources that we're starting to have available to us, which really, I think, answers the question of the infrastructure needs in terms of payment and support, and how can we organize clinical practices around taking advantage of these. I appreciate everybody on the panel for your great presentations. We have a few minutes for questions, which we had a lot of questions in the chat. I'll do my best to curate them out. So I will address these to individual panelists, but if others feel that they can contribute to the answer to the question, please feel free to go ahead. I'll go back to Mary. There were some questions about trauma-informed care, and also an overlapping area with adverse child events and the ACE questionnaire. Are these areas that you're incorporating into the subcommittee's work?
I think by virtue of the work that we do, they are included, but we haven't specifically addressed them explicitly. That's a really good question. I know at Rainbow that we definitely have. As we started to do integrated work 5 years ago, we were realizing that a lot of the referrals and the suspected diagnoses really originated from trauma. And that's why we embarked on a trauma-informed care initiative, as well as using ACEs as well as PACEs in our screening packets for universal screening, because that could definitely inform the types of interventions that we were offering, particularly with this population being a high social needs population. Average ACE scores in Cleveland are higher than the rest of Cuyahoga County, which are higher than the rest of Ohio, which are higher than the rest of the nation. We really are a hotbed of trauma here. So I don't think we can have these kinds of conversations without considering trauma-informed care. I think that's an excellent question.
Thank you so much. Next question is for Chris. And I know this is the data that you presented was specifically about the pilot, but are you aware of any data on the number of appropriate providers when we talk about the gap in terms of available resources? Is that something that we have a fix on or numbers on?
Yeah, one of the metrics we're tracking is average length of wait. And so it's always sort of a push to drive that down, with the assumption that one of the factors going into the length of wait is that sort of that capacity issue that Dr. Gabriel mentioned. But yeah, we're hoping to sort of do a better job of tracking that as it relates to the pilot. In terms of the overall community, I don't have that data. Just that's not something that we keep track of, but something that definitely comes up in the qualitative interviews when interviewing families and providers.
But it's great to know that you're keeping an eye on that, just in the overall question of access, which is really what we're all talking about. Martin, I'll address a couple questions to you as the centers have been such a great participant in the pilot. The questions were about scaling up. You presented at the end of your presentation the numbers that you hope to be able to achieve during the course of your work. What do you see are the roadblocks for scaling up? There were some specific questions about ensuring ongoing bandwidth, which gets to a little bit of that access question, and then also ensuring fidelity to the best practices.
You know, one thing that I guess having this SAMHSA grant, it has allowed us to revise our budget to include staff that can actually help ensure that clients are getting access to services quickly. So that has helped, having the funding from the SAMHSA grant to be able to assist with that. In regards to fidelity to the model, we're meeting with our GPO every month to kind of talk through everything that is expected in regards to the meeting the CCBHC requirements. We're not there in terms of everything that we need to have in place. And so it's great that SAMHSA is working with us on making sure that we're actually moving in that direction. So in regards to that, we are working with SAMHSA regarding where we are. We have most of the things in-house. There's certain things that we have to continue to work on to develop, and we continue to do that.
Thank you so much. Loren, there was a question that you answered in the chat already about whether non-providers can attend the CANS training, and hopefully people can scroll through to see your whole answer. There was a question about educating parents, and as I heard your presentation, there was an aspect of the assessment that revolved around education of the family to the needs of these medically complex patients.
Yeah, absolutely. Family planning is a big part of how this program was designed. I think, Ohio Rise, as is the case with how the department has approached procurement generally, really led with patient voices, beneficiary voices, provider voices in its design construction. I think, for those providers who are interested in educating, to check out the website for the state. There's FAQs, there's collateral materials. And I would also, I say this to my med students, don't see the insurance company as the bad guy. They are the ones that are contracted with the state. Reach out to them. Try to make that relationship proactive. Try to establish something where you see this as a partnership, because at the end of the day, the families are dealing with the same asymmetric information that all patients are, right? So if there's a way that the system in the background can better connect, between the payer and the provider to better educate folks and get them connected the right way, I think that that's ideal. And the state is wide open when it comes to answering whatever questions and providing providers with all the resources they need to be successful.
Thank you, Loren. We can go to the next slide. We are right up against the hour. I want to thank again all of our panelists for their great work and their great presentations, and being able to summarize a huge amount of information in this quite short presentation. I want to invite everybody who's on to attend our next webinar, which is scheduled for September 22nd. This will be the second part of Elevating Children's Health, focusing on mobilizing lead-safe strategies for children. You can contact Carol, whose email is right there, if you want more information or to be able to register. As Carol had noted, the slides and the recording of the presentation are going to be available on our website after we conclude. And I thank you for all your great work. Thanks to everybody who attended today, and we'll look forward to seeing you at our next webinar.